am a consultant paediatric oncologist in Oxford, and I am also the chair of the NCRI Neuroblastoma subgroup, which is, I'm going to cover that, but that's to do with the clinical trials that are going to be open, running, and monitoring them in the UK. So there are other tumour groups that have their own subgroups, just to clarify that. So I'm not going to present a lot of science or event-free survival curves. I'm just going to try and explain to you the sort of process of a patient with neuroblastoma and their clinicians looking after them, and all the sort of pathways that are associated both with the patient and the professionals, and how that links into SIOPEN and the work that SIOPEN does. So my overview will be to just explain what SIOPEN is. That stands for SIOP, which is Society International Oncologie Pédiatrique, and then the E is European, and you'll realize as I talk that it's not my or your view of Europe, it's much more extended, and N for neuroblastoma. And I'm going to talk a little bit about the trial portfolio within SIOPEN, but I'm not going to cover particularly either antibody issues. I know they were briefly discussed yesterday, and Juliette Gray, one of my colleagues in Southampton, is going to talk about that following my talk, and also relapse issues, which Dr. Morgenstern discussed yesterday. I know that many of you submitted questions for us to address, and we divided them up between the three UK people here, and I know Daniel had some yesterday. And I've got two slides. They're exactly the questions as you submitted them, and I'm going to, one is, as I've put there, then I'm going to talk about the high-risk study, the future, and then some more questions. They're the slightly more futuristic questions. And as I say, I haven't modified the questions at all. They are as you submitted them. Okay, so the history of SIOPEN. I mean, basically, in the 1980s, European collaboration started. And Dr. John Pritchard, who did a huge amount for neuroblastoma and neuroblastoma families and patients, started collaborating with our European colleagues to try and move science and clinical trials forward for this rare disease. Then, very excitingly, in 2002, when the European Union was getting going with its funding systems, there was an FP5 grant, which Ruth Ladenstein, who's a pediatric oncologist in Austria that a lot of you will have heard about, managed to secure funding for the first European high-risk neuroblastoma clinical trial. And what was really unique about this was it was going to have remote data entry. So what I mean is that all the information about any patient on the trial was going to be put onto a computer. Whereas prior to that, it had all been done with huge amounts of paper that sort of flurried around. And at that time, it's 12 years ago, that was a really pioneer moment. And so the funding enabled this large, in those days, very clunky database to be established. National coordinators from each country were involved with the clinical trials, and specialty groups. So it wasn't just the patients and all their data, it was also specialty groups, and I'll show you about that. I mean, things like radiology, bone marrow tests, and all the additional things that are part of looking after a patient and moving science and hopefully a cure forward. And then, obviously, the SIOPEN group needed to meet. So as well as telephone conference calls, maybe with an executive board who are the leaders from each country, there are also face-to-face meetings. And one thing I just really want to stress, this EU grant, it didn't pay for people traveling. People often think, oh, it's a big grant, it means we can all go to these places. No traveling, it really just paid for the database and maybe some activity within specialty groups. It didn't pay for people turning up at meetings or anything like that. That was all done basically voluntary by most of the people that attend meetings. So that was a long time ago, 2002, and now we're in 2015, and the organisation has changed hugely. And there isn't a EU grant. The grant was for 5 years. It sort of maybe went on for a couple more years. Reapplications to other funding pools within the EU were attempted but failed because it was felt we were established. And so it was established that each country that participated with patients would have to put in a UK levy, and obviously we have our UK levy. It's a growing organisation. I'm going to show you that. The database was all too out of date and clunky and unnecessary. So it had to be hugely updated. That's been a big, it's called migration. So if you have a new system, you migrate the database. And that has been happening over the last 18 months. And there are specialty groups, and there are more clinical trials. And I'm going to just explain a little bit about that. But I would like to take this point to hugely thank these charities. And I hope I've got everybody here, because a few years ago, I think I was looking more stressed than usual at work. And one of my parents said, "What have you got to do?" And I said, I've got to find £26,000 for the UK to pay as their contribution to SIOPEN. And he was sort of surprised, really, that that was on my remit, and amazingly has got the support from different charities within the UK to split that levy, and that's been happening now for the last 4 years, to which I and all the professionals involved in SIOPEN, and I hope actually all the families and parents whose children are in SIOPEN studies are very grateful, but we are very, very grateful, so thank you. What is SIOPEN? This is just the mission statement, and I want to acknowledge the huge amount of work that Daniel's done, actually. He's hugely modified or made a new website for SIOPEN, and it's called SIOPEN.org, and that, you know, he's got talents which certainly I couldn't have done a website, and we're very lucky. So that you don't need to read all this, but this is what it says on that website. So if you like, it's the mission statement. Brings together clinicians across Europe and beyond to improve the outcomes for patients with neuroblastoma and clinical trials. So that we're lucky to have that website. There is also another website which is more to do with the database. Okay, here are the countries that are involved in SIOPEN. So there are all those flags. And I think you won't need me to just explain, this doesn't look like the EU. So there's Israel, Hong Kong, Australia, Turkey. So it has extended hugely. And there are currently 26 countries. It's a changing organisation. So this slide, don't look at all the numbers, but I've just done member countries. So by country, last year and this year. So 175, 258, and you can see the split of countries. It's a little bit in transition at the moment because we're just about to have our annual meeting next week in Newcastle, so a few more people have joined up so they can attend the meeting. But if you I just put the major players, really. France, so everyone's gone up, and here's the UK. We're top 57 individuals from the UK have become members. So that's members within the country. And I think it's really important to say we're very lucky in the UK. I know there have been discussions, and maybe some of you think you're not lucky to be in the UK, but actually at a professional level, the care of children with cancer is very coordinated. And so wherever you are in the UK, you will be looked after in the same way. So you'll go to a principal treatment centre eventually, and then have care that is delivered in a relatively uniform way with a lot of collaboration between those lead professionals. That is not the same in some of the other countries. There may be 1 or 2 centres that participate like that, but not all of them. So there's more idiosyncrasy. Okay, so I want to cover little remember things. I'm sure you don't need me to say high-risk neuroblastoma, which is 50% of cases, is not one disease. I'm sure you all know that. And of course, that's an important thing to remember when you're looking at therapies. So I've just listed there's differences in response to therapy, differences in the genomics of neuroblastoma, differences in how individuals' bodies respond to neuroblastoma, and of course, how they respond to the treatment. And then I just want to remind everybody that advances in the therapy, I've put here high-risk neuroblastoma, but actually any tumour, but high-risk neuroblastoma, have come from clinical trials where there are randomizations. So we have scientific evidence that one treatment is better than another. And I've just listed some of these here, which I'm sure many of you know. So rapid Kojek, was better than when we gave the same drugs over double the length of time, and so on, so that when we established the better regime for high-dose chemotherapy. Immunotherapy, of course, is a hot topic right now, and we need to know how to give immunotherapy. So it's just to say they are the key way of moving treatments forward. Those are two little reminders. Okay, so what trials does SIOPEN have open? So currently, this isn't a totally inclusive list, but we've got the high-risk study, and I'm going to concentrate a little bit more about that. The long-term infusion study of antibody, and Dr. Gray will talk about that. LINIS, so that's for low and intermediate risk neuroblastoma patients. That's about 40% of the whole cohort of patients. Overall, their outcome is much better, but there are many important areas for this group of patients that need to be addressed. OMS, that stands for opsoclonus myoclonus, and I don't know if anyone here has been involved in that type of neuroblastoma when there are very significant associated neurological problems. But what's exciting, the reason I put that up is this is an incredibly exciting study which has taken probably at least 20 years to get open. It is open across Europe in most big countries, and it's not only involving oncologists, it's very much involving neurologists as well, because the outcome actually for these patients, the problem isn't the oncology. They do not, these children, I mean, it's very rare, do not die of their neuroblastoma, but they are left, some of them, with really severe problems from their abnormal neurology. And so there's an incredibly active parent group supporting this, but the logistics of getting a trial open, combining neurology input, so watching the outcomes in terms of development, and oncologists, and a treatment stratification depending, so there's an intensification of treatment depending on how you're responding. But it is open, and that's very, very exciting. And one of the doctors, there's been a lot of effort from doctors in Germany. Dr. Barbara Hero has been a pioneer for that, and Dr. Mike Pike in the UK. And so that's very exciting that that actually has been achieved. There aren't many studies, clinical trials, transatlantic, sorry, it's not transatlantic, just with so many people involved. We tried to participate in another study for OMS, transatlantic, and that just was fraught with, to a degree, bureaucratic and regulatory problems. Beacon, I know you heard about that yesterday. That's the relapse study in the UK. And LUDO, so a nuclear medicine approach using lutetium dotatate, and I think you may have heard about that. In development, so high-risk study, I told you it started in 2002. We need to be thinking about what's going to happen next. Veritas for very high-risk patients is in development, and there is an amendment about to be for Beacon, and there is more. Okay, so let's move on to the high-risk study. So here is a bar chart taking you through the annual recruitment. So you can see how many. So about 200 patients, over 200 patients a year are enrolled into that study. Here's the UK accrual. So this red line is what we were expecting, and you can see over the years we've had excellent recruitment into this study. And what I can say is that, or maybe I'd go on to the next study. So here's a map. Obviously, it hasn't got every participating country because it would have looked too big. So that's why they're listed down there on the right. So this shows UK, that's what I'm looking at, 555, France 555. I've looked up the population. So the current population of France is 66 million and UK 64 million. So, and I know that over 98% of patients in the UK who are eligible to go into the high-risk neuroblastoma trial are entered into it. So that our figures, our UK figures, are representative of essentially all the cases. And that's probably very key. It's maybe not so key for some of these other countries. Data capture. I'm just going to drill down a bit into how do we get, outcomes, how do we get facts and figures out of these big trials. And I hope this is information you'll find interesting. So here's a sort of rather clunky old drawing of what the SIOPEN database was, but just give, as well as information about patients, which you'll all know because these is information about your children going onto the study, and you'll know that you had to sign consent forms saying it would all be anonymized, and then every blood count, every X-ray form, and everything like that is logged on. There is information within this database for biology, information about the actual tumor, nuclear medicine scans, the MIBG scans, all the other X-rays, MRI, CT, what have I put here? Pathology, so the actual, what the pathologist sees down the microscope, radiotherapy details, when you have a stem cell harvest. So there's the surgery, the actual details of the surgery, the bone marrow, all those bone marrow tests. So there's a huge amount of data there. So there is data from 26 countries, at least 100 centres, and currently there are over 2,500 patients who are in the database who have been or are still on and receiving treatment in the high-risk study. And that is a huge number. So let's just drill down a bit more. I'm going to talk about a UK patient. So a new patient, I'm now talking about high-risk patients, which I appreciate is only 50%, but it's just to illustrate a point. So a patient is poorly, and they will eventually maybe get to a GP surgery or possibly go straight to a hospital in A&E, and then they will need to go to in this country we call them principal treatment centres. So that's where there's a centre that is used to looking after children with a malignancy. And of course, that route in itself can be quite tortuous. In the UK, the CCLG is our professional organisation for all disciplines of people who are looking after children with cancer. And there are these centres here. I know Oxford is in a very strange place on this slide, but these are the centres here, as you can see. And every now and then they're slightly changed, but that's essentially where we are at the moment, and there may be reconfiguration. Now, just a little to divert, in terms of all the people looking after your children, there are an increasing number of other organisations controlling us, I think. So our arm's length bodies. And actually, if I go through this for a child having treatment for neuroblastoma, many of these organisations are involved. So at a professional level, we're having to cope with all of this in our different centres. The MHRA, that's to do with drugs. NHS England. We're not the UK anymore at a medical level. Everything's honed in, and we're now NHS England. So at a practical level, for all the professionals looking after your children, this is causing quite some liveliness, I shall say. And this is to do with reorganisations within the NHS and with medical care, but it's a challenge out there. So our friends in Wales and Scotland are sort of actually not particularly wanting, our colleagues wanting to be excluded, but NHS England is saying, no, we're talking about England. So Public Health England, CQC, everyone will have heard about that. We're being inspected all the time. NICE, I know there's been a little bit of discussion about that. Blood transfusion. So we don't need to dwell on that, but those are all aspects that we have to deal with. Okay, so just go back to a patient. I've talked about principal treatment centres. You've seen where they are. And, of course, many children will opt to give their care, shared care units as well, so there'll be communication going between the two. The CCLG is our professional body, and I hope some of you have seen they have supported neuroblastoma hugely, and there are some new booklets just come out. They've partnered the updated neuroblastoma patients and parents booklet and also a new parent guide for options at relapse. So that's hot off the press, and there are some here. And there's a special interest group of professionals, of which Daniel is the chair, and many of us who are in this group are also in that group, but the membership is much wider. And then the NCRI, Children's Cancer and Leukemia Clinical Study Group, is a very important organisation, particularly focused at clinical trial activity. So any clinical trial that we're thinking about, or are running or want to run goes through this body. And this is children's, and neuroblastoma is a subgroup. And there are all adults' cancers have their own clinical study groups. And that's a large organization. The remit is clinical trials. And for children's cancer, most of the clinical trials units, that's the body that looks after the nitty-gritty of clinical trial activity and data collection, is at Birmingham, funded by CRUK. Okay, and we'll just go through this very quickly, but it's just to say that, and I know there's frustration from the floor about what you see as us being slow, but we have to, well, maybe compete isn't the right word, but, you know, neuroblastoma is one disease, and there are other diseases. So here's the current portfolio of trials open at the CRCTU, but so we're looking at rhabdomyosarcoma, Ewing's, leukemia, Hodgkin's disease. So we don't need to dwell on that, but it's just to sort of make that point. But actually, we're quite well represented. Sorry, I should have, there's obviously, there's there's the high-risk study, and then if we look at early phase trials, actually, neuroblastoma is doing pretty well. So there's the long-term infusional study and more. Beacon. Okay, data capture. So I just want to highlight this, and this is one of my dear patients, and her parents are happy that I show this slide. This pile is her hospital notes, and actually there's probably another volume on top. And this is her, and she went right through the high-risk study and had immunotherapy. So here we are in Oxford, all of those notes, and somehow all those bits, all the information in those notes has to get onto that database. Now, there are 137 forms per patient. I asked our data manager last week. And of those 137 data forms, there are between about 20 to 100 bits of information going onto them, which are then fed electronically into this database. It is a huge amount of information. So I don't know if everyone knew that, but I just thought this slide illustrated it. That's not to mention follow-up forms. So that's the sort of background to some of those slides that you've been seeing over this weekend. I asked him which was the sort of most difficult to fill in. So this is just a little capture of it. He told me the most traumatizing form is the form that's called primary tumor relationship to vessels. This is not when it's out. It's like when you take you do an MRI scan or CT scan of the tumor, let's say in the abdomen, but it could be in the neck, could be in the pelvis. And this is an amazing form, which no way could a data manager fill in. I can't fill it in. Even the radiologists struggle. So there's just asks you things, you know, is the aorta separate, contact, NKs, the porta hepatis, that goes through. This is just a little bit of this form. So that's just to give you an example. Anyway, what do we end up with? We end up with all that data on over 2,500 patients on the database. It is a true treasure chest. It has to be. There's so much information. Oh my goodness, I've got 5 minutes to go. So that is very exciting. And some treasure has been found already. I'm going to whiz through that. And hopefully we'll find some more. But I just hope that's giving you an idea about, you know, it seems like you have the patients, they go through the study, we should know the answers. But it isn't quite so straightforward. Okay, so we'll whiz through this because I suspect a lot of you know that. So the high-risk study has had lots of randomizations in it. It's pretty lucky, to be honest, in the UK that we managed to get the last randomization through. This is number 5. So everyone says, what are you doing? This should be a new study. And actually, some of the other countries have that problem. So we've had 5 randomizations. You know about R0. That's why children have GCSF to support them through intensive treatment. Great. Myeloablative therapy, we showed a benefit to the patients that had busulfan and melphalan rather than SEM, the alternative one. I should actually acknowledge that some of these slides are Daniel's from his talk last year. Thank you. Not many of them, but these ones. Immunotherapy, and I'll gloss over that. So we've been looking at how best to give immunotherapy, and Juliet's going to talk but at the moment it's not clear about the benefit in terms of outcome improvement when IL-2 is added, but that's because of the toxicity has meant that they've had less of the treatment. Other works going on, drilling down into this treasure chest, and there's information that looks as though if you've had a complete excision of your primary tumour, you do better. But of course, that is a little bit chicken and egg. Which comes first? Is it that the patients whose tumours were going to be easier to resect were going to do better anyway, or which way round is it? So you always have to look carefully at what you're doing. Currently, there's an induction randomization, so we're looking to see if we can improve the extent of metastatic or the bone marrow and bone disease improvement with a different induction regime. And then Juliet will talk about the R4 randomization, which is the immunotherapy randomization. Okay, other studies. The low and intermediate risk study is running along, and that is looking at actually trying to reduce treatment for some good risk patients. So that's exciting. We have to remember that. It's stratified by stage, age, and also biology. So some science going into SIOPEN. And this is Gudrun Schleiermacher's slide, hot off the press for our meeting next week, just showing the type of techniques she's used to not just get MYC amplification. Those patients aren't actually eligible for this trial, but we're now looking much more extensively at the genomic profiling within these patients, particularly in the low and intermediate risk patients, to see if that will identify some patients that need more or less treatment. So this is the different techniques that she's used. I won't go into those details. Beacon, I think this was covered yesterday, so that's exciting, and we're really pleased to have a trial that's up and running and recruiting well and continuing to be modified. So this study thought about the time that it was taken to run or open a trial. And so it's got a sort of backbone, which means that we can make rolling amendments so you won't get that lag phase in opening. That's what I said about the OMS study, and these are all the groups that are contributing to it. So that's part of that work. And currently, that's the recruitment for the OMS study there. And this is Mark Gaze's study using lutetium dotatate in either primary refractory or relapsed high-risk neuroblastoma. This is an exciting study, which at the moment is being done at UCLH. Okay, what's next for SIOPEN? Clearly, the high-risk study will finish, and we'll need to have another one. So at the moment, there's a huge analysis of the data on that database, and that needs to be done. Think tanks have been set up to actually drill into certain areas of key importance for looking at in the next high-risk study. And I've already been asked this question by a parent. SIOPEN, you might have noticed when I went through those flags, there wasn't a German flag. And for historical reasons, Germany hasn't been part of SIOPEN. They have a population of 80 million and have had a very well-organized program of clinical trials. But excitingly, it is very likely, or there's definite very good intent, for Germany to participate in the next high-risk study, which we're really probably looking at 2017, 2018 before that opens. So that is excellent for collaboration. Veritas is a study that's being worked up for very high-risk patients who are identified by one means or another. And of course, new agents is an important part of what goes on in the high-risk study. That's just really going through some of these think tanks. And I think what I wanted particularly to say, so again, this is hot off the press, so this is where us lot will be going next week to Newcastle, so where that's the SIOPEN AGM. It's just chance that it's being hosted in the UK. We go around all the different countries. And what you can see here, if I just highlight it, think tank session. So this is I think this is on Thursday morning, and we're going through these criteria, just trying to work out what facts we have got from the database from the current high-risk study, and how we're going to incorporate the questions that arise from that into making good randomized questions for the next high-risk study. And local treatment, I'll just give you an example. So that's where we're talking about surgery and radiotherapy. And without doubt, there will be a randomized question about radiotherapy in the next high-risk study. So it's just to give you an example. But there will be other many other questions.